Assalamualaikum and hi everyone. Welcome back to my channel. I'm Hamallee Harun, student of NHSI 4B, degree in medical imaging, Uitm Puncak. This video is part of my project for the subject Radiographic Image Evaluation, and today we are going to talk about how to evaluate APNIs with placement method. In this part of the video, I will walk you through the basic anatomical landmark, positioning, exposure factor, and the common error when taking an AP view of the knee. Let's begin by looking at the anatomy. In an AP knee radiograph, the upper part of the image show the distal end of the femur and the patella. Let's break it down. On the femur, you should clearly see the medial and lateral condyle. These are the rounded ends that form the knee joint. And then we can see the medial and lateral epicondyle. This is a small bony projection just above the condyle. And then we can see the adductor tubercle. It is located on the middle side and it serves as an attachment for muscle. Also, the facet for the popliteus is the part of the muscle attachment side on the lateral side of the knee. And then we can see the intercondylar fossa, a deep notch between the condyles visibly clearly if properly exposed. The patella or kneecap is also seen. You should identify both of the superior and inferior posts. In AP projection, the patella should be superimposed over the distal femur. Recognizing this landmark is important to assess bone alignment and detect abnormalities. Now, we focus on the lower part of the AP knee image. This image shows the proximal tibia and fibula. For the tibia, the key structures are, first we can look for the tibia plateau. Tibia plateau is the flat surface that articulates with femur. Then we can see the tibial tubercle. This tubercle is the patellar ligament insertion. And then we can see the medial and lateral condyle. This condyle is the upper parts of tibia that support body weight. Then we can see the intercondylar eminence. The intercondylar eminence is a bony ridge in the center of the plateau that fits into the intercondylar fossa of the femur. And now we look for the fibula. At the fibula side, we can see the apex, also called the stylo process, the head. The head is slightly below the tibia plateau, and the neck just distal to the head. As we can see here, you will notice the medial and lateral tibiofemoral compartment. This compartment is where the degenerative changes often occur. Knowing this structure help when evaluating trauma, arthritis, or knee joint disorder. Correct positioning is essential to obtain a diagnostic AP knee image. When we talk about the criteria of positioning, we must clearly know how to position the patient correctly. First, we should ask the patient to be supine position, lying flat on the table. And then, we must ensure the knee and the ankle joint are in full contact with the table to keeping the leg straight. And the knee must not be rotated. And we can do a slight internal rotation of 3 to 5 degrees of the foot to bring the knee joint parallel to the detector. For the technical factor, we use the projection of anterior-posterior AP. The centering point is approximately 1.5 cm distal to the apex of the patella. Collimation is very important. So the superior part, we must include the distal femur, and then the inferior part, we must include the proximal tibia and fibula. And the lateral and medial part, we must include the skin margin. Proper positioning ensures symmetry and allow accurate evaluation of joint space, alignment, and anatomy. Once the image is taken, technically evaluation is needed to confirm image quality. Some tips for the beginners. First, the femoral and tibial condyle should appear symmetrical. This is to indicate that the knee is not rotated. The second one is the head of fibula should be slightly superimposed by the lateral tibial condyle. If it is fully hidden or too visible, rotation is likely off. And then the last one, the patella should be lie centrally over the distal femur, not shifted medially or laterally. This evaluation helps confirm both proper positioning and adequate exposure. Any asymmetry or misalignment indicate incorrect technique and may require a repeat image. Here's a critical reminder for anyone positioning an AP knee. If the fibula head is completely superimposed, the image is not an AP projection. This usually happens due to external rotation of the leg. To correct this, you must internally rotate the leg until the knee is even contact with the image receptor. When done correctly, the fibula head will only be slightly superimposed, not fully hidden. Always check the rotation before taking the exposure. This simple step can avoid the need for repeat. You can use this following range for a standard adult apnea. We can use 60 to 70 kVp and 7 to 10 MAS. These settings are enough to penetrate both thick and thin areas of the knee, providing a good balance between bone cortical outline and trabecular bone pattern. A good exposure allows you to see dense cortical bone along the edges of femur, tibia, and fibula. Find trabecular inside the medullary cavity, especially around the corners. Remember, underexposure leads to noisy and unclear image. Overexposure may hide fine bone detail. So, always adjust according to patient size and body habitus. Let's be real. In the radiography world, a good image isn't just about pressing a button. It's about producing a diagnostic quality image that can help doctors make the right decision for the patient. Placement really helps radiographers to avoid careless mistake and to ensure every critical detail is captured and to maintain consistency across all examination. Before we dive into applying the placement method, let's take a moment to understand what exactly is placement. Placement is a systematic method used by radiographers to evaluate radiographic image. Each letter stands for an important element to check. P is for positioning, A for anatomy, C collimation, E exposure, M marker, A artifact, and the last one is N for name and label. This method works like a checklist to make sure our image meets the required standard, not just technically, but also professionally. Let's start our space-based evaluation with the first step, the P, identifying the part and projection. Based on the graph shown here, this is an AP knee projection or anterior posterior view for knee. How we do know that? In this image, we can clearly see the distal end of the femur, then the proximal tibia and fibula, and the patella, which is superimposed over the femur. All of these structures are centered nicely in the image, which is a classic features of an AP knee radiograph. In this projection, the central ray is directed vertically from front to back, perpendicular to the image receptor and the knee joint. Now, from this radiograph, let's talk about the positioning of this AP knee radiograph. From what we see here, the positioning appears correct based on several important criteria. Firstly, we look at the lateral and medial epicondyle of the femur. Both are clearly visible in profile. This indicates that the knee is not rotated. Secondly, we can see the intercondylar eminence, the body ridge between the tibia amplitude. It is well centered within the intercondylar fossa of the femur. Third, the head of fibula is slightly superimposed by the lateral tibial condyle. This is exactly what we expect in a proper AP projection. If the fibula is completely hidden or too visible, that would be suggest as a rotation. Now look at the femorotibial joint space. It's open and symmetrical. This tells us the central ray was directed properly and the knee was in a neutral position. Finally, we look at the center of the collimation field. It is approximately 1.5 centimeter below the apex of the patella, which is the correct centering point for this projection. So for me, the overall, all the key landmarks are in the right place. This means the positioning of for this AP radiograph is accurate and meets diagnostic standard. Before that, let's take our evaluation of positioning a step further by learning how to detect the rotation in AP radiograph. Remember, Rotation can affect the symmetry of the knee and make the image non-diagnostic. So, how do we know if the knee is rotated? Uh, we can evaluate two key things. First, the size of the femoral condyle, and the second one is the relationship between the fibula head and the tibia. Let's start with the internal medial rotation. In this case, the lateral femoral condyle appear larger than the medial condyle. You also notice that the fibula head is barely superimposed by the tibia. This suggests that the leg is rotated too far inward. Now, look at the external or lateral rotation. Here, the medial femoral condyle appear larger. Then the fibula head, neck, and even the shaft are heavily superimposed by the tibia. This happens when the leg is rotated too far outward. So, what's the ideal? In a proper knee, the condyle should be symmetrical and the fibula head should be slightly superimposed, just enough to confirm correct rotation. Correcting the leg rotation, we can rotate the foot 3 to 5 degree inward or outward. Even just a few degrees make a big difference in image quality. Uh, Always double check before hitting that exposure button. Alignment. Okay, we look at the alignment. The alignment refer to how well the X-ray tube, patient, and image receptor are lined up. In this image, we evaluate alignment based on three key relationships. The first is we look the relationship between X-ray tube and patient. Unfortunately, this cannot be fully determined because there is no visible collimation in the radiograph. Collimation helps us judge if the central ray was truly perpendicular to the patient body. Without it, we cannot confirm it if the beam was aligned correctly with the knee joint. The second one is we can look at the between X-ray tube and cassette. Again, this is cannot be assessed due to the lack of collimation mark. Normally, we look for the straight collimation border to confirm the beam was perpendicular to the image receptor. So, in this case, we have limited information between patient and cassette. Here, what we can confirm, the patient appear well aligned with the image receptor. I say so because the distance between the knee joint and the lateral edges of the film is equal. The anatomy is centered, showing good midline positioning. This tells us that the patient was not rotated or shifted off center during the exposure. The center ray appears correctly, centered at around 1.5 centimeter below the apex of the patella, which is ideal for knee AP projection. For this photograph, we assess collimation based on four directions. Superiorly, the image includes the distal part of the femur, which is important to assess joint space and alignment. Inferiorly, we can see the proximal part of both tibia and fibula, so that's acceptable. On the lateral and medial side, both skin margins are visible, showing that the beam captured the full width of the knee without unnecessary exposure to surrounding areas. This is what we want, a balance between full anatomical coverage and minimized exposure. However, one thing to note here, there is no clear evidence of collimation border visible in this image. That usually happens when the field is too wide or when the exposure setting over penetrate the collimation edge. Also, there is no sign of radiation protection apparatus being used, like shielding or whatsoever lah. In summary for this, the anatomical coverage is good, but the collimation edges and radiation safety measure could be improved for more complete professional radiographic practice. So, we must give radiation protection apparatus on this patient. Now, let's evaluate the exposure used in this radiograph. We assess exposure using two main aspects. We look at contrast and density. For the contrast is the ability to distinguish structure of different thickness in this radiograph. Okay, for thin structure, like the bony cortical outline of the medial and lateral epicondyles, the edges are clearly visible. This means contrast is acceptable for thin area. For the thick structure, we can look at bony cortical outline of the patella. We can still accept and appreciate the outer border as well, indicating the sufficient contrast even in dense area. Now, let's look at the density, which refer to the blackness or overall brightness of the image. In thin structure, we can see the bony trabecular pattern within the lateral and medial epicondyle. It's showing that density is not too high or not too low. In tissue area, like the femoral condyle, the bony trabecular pattern details are still visible, confirming that the exposure allow proper penetration. So, for the conclusion, the KVP and MAS used in this radiograph appear to be adequate because they provide the right balance of penetration, contrast, detail, and density. This ensures that both fine internal structure and outer body outline are well demonstrated, making the image useful for diagnostic interpretation. Let's evaluate the marker in this AP radiograph. First, we look at the anatomical marker R, which stands for right, is clearly visible on the image. This is important because it tells us which side of the patient is being imaged, helping to avoid any clinical confusion during diagnosis. Secondly, the marker is placed correctly. The marker not obscure any anatomy and outside of the area of interest, and in the position within the exposure field, not too close to the edge or cut off. This is good practice for all radiographer to be followed. The third one is the marker correspond the correct side of the patient, meaning this was indeed the right knee and the label confirm it. Always remember, a missing or wrongly placed marker can lead to the serious interpretation error, especially in trauma or surgery cases. So, this step, although small, is crucial for legal, diagnostic, and professional purpose. Another important step in the placement image evaluation method is artifact. Artifact refer to anything that appear on on a radiograph, but is not part of the patient anatomy, like clothes, jewelry, motion blur, or external object. In this radiograph, no artifact is seen, which is good. There are no foreign object, no patient motion, and nothing that interfere with the visibility of the knee structures. The film size used is also appropriate. This radiograph was taken using a 10-inch cassette, which is suitable to cover the distal femur, the proximal tibia and fibula, and all required soft tissue. This ensures the anatomy fit well within the image field without excessive exposure or cut-off margin. Always remember, to all my friends, artifact may hide fractures, mimic pathology, or cause diagnostic error. So, this is important to make sure the patient remove any unnecessary item before exposure. And finally, we are arrived at the last component of the placement method, the name and ID. This is a step. This step is all about ensuring the patient identity is correctly recorded on the radiograph. In this image, all necessary identification details are present. We look at the facility name, the patient name and registration number, and the date and time of examination. All of this is clearly displayed and easy to read. Also, the placement of ID block is correct. It is located at the corner of the image and does not overlap or obscure any part of knee joint or surrounding anatomy. That's exactly what we want. ID that is clear but doesn't get in the way. Why it is important? Without proper ID, the image can be matched to the correct patient. In emergency setting, this could lead to serious medical or legal consequences. Overall, the image is acceptable for diagnostic use with tolerable and correctable error. The main point for improvement lies in the collimation technique, as there a lack of visible collimation border, which make it difficult to assess alignment between the X-ray tube and the patient or cassette. However, the positioning, the exposure, marker placement, and image quality are well executed. This patient is centered, the trabecular pattern and cortical detail are visible, and there are no artifacts interfering with interpretation. As a radiographer, we must aim to improve to be consistent with beam limitation, and we must ensure every image prioritize diagnostic quality and patient safety. To support this presentation, I refer to several reliable radiography textbooks that help me to understand the positioning and evaluation criteria better. This is four main books I use. The first one is Radiographic Image Analysis by Katie McQuillan. And then I use the pocketbook guide to Radiographic Image Evaluation. And I also use Bontrager and Clark for positioning in radiography. These books are very useful, especially when you are learning how to apply evaluation method like placement, not just for exam, but in the clinical practice too. That's it for the video. I hope my sharing about the placement method can make you become more confident in evaluating radiograph. Till we meet again, I'm Hamallee Harun. See you next time. Bye.